Today we've got the opportunity to start another fantastic and unique lecture that is going to be provided by excellent Professor Christiane Richter-Ehrenstein from the Department of Obstetrics and Gynecology from Frankfurt. It's going to be really interesting. It's going to touch the very serious problems regarding embryology. So I strongly invite you for listening to this extraordinary lecture. And firstly, before we start, I would like to invite our rector of university, Professor Leszek Domański.
Hello everybody, dear colleagues and students. I'm very, very happy that we have today our meeting and lecture. We continue our meetings with science, and today we have the special guest, Professor Richter-Ehrenstein, our professor of Pomeranian Medical University. Thank you very much for coming to us. Absolutely expert on the field of obstetrics in gynecology, breast cancer too, absolutely. And I'm very, very happy. Christina, thank you very much for coming, and for all, I'm really thank you for helping our university, because Professor Christiane Richter-Ehrenstein is responsible for teaching our students in Frankfurt Oder. We send our students for the practical year. It's a fantastic place, and if you have a question about it, please, Professor is today with us. Thank you very much for coming, guys, and the floor is yours.
Okay, I thought it's a small group, but now thank you very much for giving me the opportunity to talk to you as students and as guests and the whole faculty, and I'm very honored to be with you. And I'm a little bit, I have the, beschämt, I don't know the proper English word for it, because there are so many people I know, students I know from the clinic and from Frankfurt, and I now want to give a short talk about fetal programming. The topic is the lifetime health under the control of the health in utero? The definition of the word fetal programming, perhaps you don't heard about it, is the theory that suggests that environmental factors during fetal development affect diseases risks. So a little bit going back, the first who mentioned this fetal programming was Mr. Barker. And the hypothesis which is behind it is the Barker's hypothesis. And he studies in the 80s that the prevalence of some adult diseases such as atherosclerosis, high blood pressure, stroke, type 2 diabetes, and dyslipidemia was related to intrauterine growth and environmental. Additional research in the last 20 years over the past decades support this relationship. There was a famous study which was called the Dutch cohort. During the World War II, the citizens of Amsterdam suffered a 9-month food blockade by the Nazi army. The historical records allowed the scientific community to study the effects of famine on offspring health. From September 1944 to May 1945, a major fraction of the Dutch population lived on less than 1,000 calories a day. The famine was sharply described in a place. This was the opportunity of this data. The affected population had major problems obtaining food elsewhere, and the famine conditions were relatively common and constant. The population was ethnically homogeneous, and the local food ratio was well known. So the availability of food was largely unaffected by social classes, and the long-term follow-up was possible since individuals in Holland could be traced through medical national population registers. So the Dutch hunger winter provided science and clinical medicine with the population of pregnant mothers and fetuses experienced malnutrition in first, second, and third trimester, plus the childhood and adult medical history of the fetuses that survived. The results and the conclusion, which were first described in molecular cell chronology in 2001 by Roosbaum, he's a Dutch epidemiologist, that there's a strong relationship between adult blood pressure and low birth weight, and between impaired glucose tolerance and low birth weight. This was not the only evidence. There were two large studies in Finland, from Finland and from Helsinki. And in the large cohort study from Uppsala, there were 15,000 patients where we could see the high association between low birth weight and coronary heart disease and 2-type diabetes. And we see in a retrospective cohort study from Helsinki in 13,000 patients that the results showed that children who showed the greatest growth changes and ultimately became obese in adulthood had the highest risk for hypertension, cardiovascular disease, and type 2 diabetes. So, in a systematic review by 60,000 patients, which was published in 96, they supported strongly this association between birth weight, low birth weight, and increased blood pressure. So, what are the causes of intrauterine growth restriction? First, the fetus does not realize its full potential growth. This is mainly due to placental insufficiency, which can be due to malnutrition by the mother, to smoking of the mother, to drugs, to obesity of the mother, congenital infections, and chromosomal abnormalities. In this slide, you see the effect of birth weight for small for gestational age and large for gestational age. The fetuses who have the problem of malnutrition, mostly malnutrition, have a higher risk of cardiovascular disease, diabetes 2, metabolic syndrome, and high blood pressure. On the other hand, if you have large gestational fetuses, which are too big for their age, they have the problem of obesity later on and type 2 diabetes as well. So if you see on this slide, it's a little bit a busy slide, just go through it with me. You see the effect of nutrition on generations. First of all, in the uterine environment and the preconceptional phase, maternal diet is very important for the fetus and the conception. If you look then on the oocyte and the embryo responses to epigenetic modifications of the nutrition status. It makes some metabolic stresses, apoptosis, and the cells are altered in their differentiation, in their proliferation. The fetal, as is individuum, has potential consequences. That means that you have epigenetic changes. So it means that genes are altered in their regulation by malnutrition. You have altered fetal growth, altered setting of neuroendocrine axis, and an abnormal birth weight. In the consequences later on, you see impaired neurodevelopmental effects, what we see, obesity and cardiovascular diseases. So in this slide, you see in the overview which organs are affected by malnutrition of the mother. First, we have on the left side, the maternal nutrition status, which can be poor, disbalanced, or excessive. You have tobacco, you have smoking, and you have, for at least, infections and chromosomal problems. On the other side, fetal programming is then affected by epigenetic problems of the fetal program, which by DNA methylation, dynamic reprogramming, and what is most important is the dysfunction of endothelium progenitor cells. As you see within this overview, you have different diseases in groups which are affected. So we go through it on every different organ system. The cardiovascular system. We have a strong negative correlation with hypertension, coronary disease, and stroke was found. When we have children which rapidly gained postnatal catch-up growth, have additionally promotes the development of these problems in their adulthood. They have a decreased elasticity and delayed vasodilatation. They have an inadequate maturation of cardiomyocytes, and they have, which is one of the most prominent problems, a dysfunction of endothelial progenitor cells. When you look for another system, the endothelial stem cells from infants with low birth weight have less angiogenetic potential, they have less capillary density, less vascular diameter, and endothelial cell proliferation and vasodilatation is reduced. And as a function in skeletal muscle, they are leading a decreased oxidative capacity, a mitochondrial dysfunction, and show an insulin resistance. Insulin resistance, as cause for diabetes mellitus, you have a decreased number of pancreatic E cells with a reduced ability to produce insulin, which is caused in a smaller size of the pancreas. You have insulin resistance with a higher level of myoinositol, and you have changes involved that alter physiologist hormonal secretion and glucose and lipid metabolism. You have, and this is one of the most prominent findings, a pro-inflammatory reaction, which due to hyperglycemia, and then this is associated with blood vessel narrowing. The increased maternal cortisol, which is produced by the stress of the fetal mother, are responsible for increased atherosclerosis, insulin resistance, and obesity. As we have a look on the kidney and liver function, you have a reduction of number of nephrons lead to abnormal glomerular filtration rate. You have a dysregulation of the endocrine system, and you have a decreased liver function, which is caused by reduced size of the liver. The immune disorders, which we can look at as diabetes, you have the problem of these pro-inflammatory cytokines, which are involved in many of our adult diseases, which we see. And you have, but which is fortunate, a reduced risk of subsequent allergies, atopic dermatitis and food allergy. This is the one thing, the only one thing these children have in favor. The knowledge about the neurological disorder which are produced or which have an influence by the malnutrition women and the very low birth weight children have a potential adverse effect on short and long-term neurodevelopmental outcomes, and we now learn to know that disorders as anxiety, depression, low cognitive abilities, and schizophrenia seems to be related to this kind of fetal growth. So as we go back to this overview, we have, as we see, perhaps the most important phase in our life is the life in utero, which causes diseases which we as adults suffer of. So these phases of the life which we can't see because we have only small capabilities of looking inside, but birth weight is one sign of a problem in being in utero, is now coming to a way where we have to discuss whether we can change this. So this is an overview about the cytokines and effects, but I don't go through it because it's too excessive. But overall, the in utero life is one of the most important phases in our life. And so we have to think about, as obstetricians, as physicians and embryologists, as to be very keen on helping mothers getting babies which are not malnourished. So, in the conclusion, the fetal program might dispose people to certain adult diseases. There is clear epidemiological evidence for it, like in the Dutch cohort, in the Helsinki cohort, and the data from Uppsala. But, however, the mechanisms for fetal programming remains a hypothesis, and we have to understand and study the mechanism at the cellular and molecular level, which is still, I think this is your way we have to wait for the new doctors to do this for us as well as with us together. But it's in the moment we are not coming to a clear point whether this is more than a hypothesis, but there's strong evidence that that has to have a very important signal for our being a healthy adult in life. So, this was my talk, very short talk about fetal programming. I would like to invite you for the Health Campus Frankfurt-Oder, where I'm belonging to, and these are some photos from us, and I thank you very much for your attention.
Thank you very much. Thank you very much for your interesting lecture. It was a pleasure to hear it, and we are all grateful for it. So I would like to start a short discussion. So maybe anyone, the students would like to ask a question, or the tutors. We've got one question. This one.
A bit of a question, but the comments. Maybe I start from the short history. We know with Professor many years. I remember my first official event when I had a lecture and she prepared to audience in contact with the people outstanding. And but exactly my words very interested in this subject. This is, you know, this is my focus of interest. And the placenta insufficiency is my higher goal. So this may just if you look at the patient in the pregnancy. So patient in pregnancy, they have adapted to totally new environment, and definitely fetus total new environment. And just if we talk about the placental insufficiency, it developed cause placenta working not well. And definitely we don't know why is placenta working not well. First, she had a predisposition to this situation, or she developed this predisposition. And the same situation is here. There's environment outside uterus, after delivery, make the children start to develop diseases, or we should make a step back, like uterus, and the fetus develop adaptation in the uterus environment, and after that we have the results. And of course, it's a long discussion. And maybe we concentrate, we talk about the cardiovascular diseases, about the neurological diseases, but very interesting issue is the polycystic ovary syndrome. This is a very interesting question because on this audience probably many women suffer this kind of the diseases, and we consider that exactly this condition comes also from the uterus, from the pregnancy, because the insulin resistance developed in this moment. So, we don't know precisely, and I can't answer this moment on the main questions from this lecture, but definitely we should concentrate and stratify just after delivery the patient from the without complication in the pregnancy and the with complication, and make very high attention to these children who suffer in the pregnancy, because it can be the high risk, potential high risk. And up to this moment, we have no stratification. Pregnancy is ended, and we treat the baby in the same way. And this is probably the most important issue from this lecture. We should concentrate. And as I really great introduce later my colleague from the neonatology, we discussed about Professor Wojcicka. Let's how to create a new approach to care, not only during the pregnancy, but also after that. Yeah? That's just only comments, sorry,
Thank you very much. I just want to comment on this very shortly. As I was doing my obstetrician training in Berlin, I was for 1 year in the neonatology department, and there the chief of the department, Professor Versmold, told us to give the neonates, which are very small, enough food to compensate for their in utero malnutrition. But if we see this and the dates, then perhaps 30 years ago it was the wrong way, because now we know that children coming from mothers who are with a very low birth weight have to adapt very slowly on the different diet which we would like to give them. So, as you see, 30 years ago, we were treating these babies that they have very nice round faces, but this is the wrong way. And now, in 30 years, we see that this was an attitude which was probably, we think it was okay, but it wasn't okay.
Yes, exactly. That's in Poland it's happened 10 years. 10 years ago. So this is small difference, but we know the catch up just after delivery is definitely not acceptable.
Yeah, right. Yeah, yeah, right.
Yeah, I give you a bit.
Okay, thank you. Thank you very much. Other questions? Yes.
Thank you very much for this very interesting lecture, and as we introduced to each other, my name is Christiane and I am a pediatrician, and I am especially interested in inborn errors of metabolism, and many of my students here know that one of the topics that we are especially focusing on is phenylketonuria, which is the best example of how poor environment during the prenatal life of the fetus, which may deliver with PTU or may not, it depends on the father's genotype, how hyperphenylalanemia in the mom suffering from phenylketonuria can effectively and very strongly affect the development of the newborn. And I just today had a seminar with our 4th-year Polish students, and we were discussing the influence of mom's high feed when she is not following the strict low phenylalanine diet before and during the pregnancy, how it can severely and irreversibly affect the development of the fetus. So thank you very much for underlying the influence of the fetus status during the pregnancy for their future life. So thank you very much. I don't know if you have any connection with the mothers, with PTU and the pregnancy? Do you have...
No, on a normal level, but not in a special way. So you, I think, more the specialist than me in treating this woman. But
well,
I think
this is a problem which is common for all countries in the world, that the mothers who are not following the diet before and during pregnancy can deliver dramatically after this child.
Thank you very much for your comment. Thank you.
Any questions from students? Do you have students from first year here? No? Second? Third? Fourth? So 5th year only. Okay, any questions?
No. I think which is one common feature which you perhaps see in your future life as a doctor is that you make an observation. And this observation, like the Dutch cohort, can visualize how important it is to realize what is going on next to you, which are the common features that you see, but you have no idea why is it this way. And this is scientific working, looking for what are the reasons that people behave or that they have different diseases or whatever, and they have a common ground. And what I think this Dutch cohort study is fundamental, special, because you see in this field, it was a horrible war, And you see in the children which were born in this time, they had the same amount or the same raise in blood pressure and all this stuff. And in this time, it wasn't important that they have, as a 50-year-old man, high blood pressure because they had other problems. But you see, this is the way scientific progress is made, by observational and very strictly observational studies, and then you can see what we have to look for in finding the mechanisms why it is this way. And this is, I think, an example for scientific work, finding and recognizing what is next to you and then finding the way why it is this way. I think this is a factor which is all over in medicine, the case. We don't know why it is this way, but you see, if we don't know, and then we have to go forward and looking forward why it is this way. And I think in this field of fetal programming, we are not really ahead of the scientific, it's beginning. And then so like Professor Kwiatkowski, he is treating the mothers who have babies and in utero, which are very low birth weight, and have to think what we can do for them. We don't have to treat the mothers better, but we have to think how we can control the other options. So, somebody else with some easy questions.
Hello, great talk. My name is Tomasz Wojtacz. I am a PI in the unit of clinical epigenetics, and that's my field of expertise. And I'm actually a bit disappointed about the students because not far as on Friday I talked about the epigenetic reprogramming, fetal reprogramming. I talked about your talk that you're going to be on today, on Tuesday, talk about it. And then my question is, what do we do about it from the clinical standpoint? But before I ask that question, what I need to say is that this has sparked, that hunger has sparked the new field in epigenetics, because suddenly nobody thought that epigenetic changes can be inherited, can go through the germline 2 times in our lifetime. Everything gets erased and put back on, not to get through the generation. And suddenly we see that there is an effect on the second generation, in the third number. Now the guy that sits in the, actually he's my friend, the one that is dealing with this cohort now, epidemiologist, and he can see the effect in the third generation. And at the moment we also talk a lot about the children of the winter, Canadian winter, 1998. There was heavy winter in part of Canada. I think for 8 to 10 weeks that part was cut out, and the mothers were under a huge stress at that point. Nothing worked itself. And those children are now in their teens, and we see high frequency of psychiatric problems in those children. And the evidence, well, we can discuss that, because there's a lot of epidemiological evidence, some of molecular, but yeah, well, it must be epigenetics. DNA has not changed, so it must be epigenetics. And what I'm wondering now, I'm not doing any research in that field, I just know of it because of being in the field. But how do we go about it? Because with foliate supplementation, well, we sorted out the neurological problem, the development problem. We simply added foliate to the, Americans even fortify now food with the foliate, which is, I don't know if it's good or bad, well, we'll see. Coming to what we do need to do now is somehow address the problem. And one of the address of the problem was overfeeding the children after birth, that it has changed. Because the theory said that if you had not enough food during pregnancy, you are prepared not to have food after pregnancy. And then if you're in an environment with opulent food levels, you can develop diabetes. And if you have any ideas of the projects to develop to address this problem, I would be very much interested in in going into something like that, because it's a very hot subject at the moment in the field of clinical epigenetics.
Oh, thank you very much for your question. I think the neurological problems and psychiatry problems are much prominent than we think of. To find insulin resistance is easy, or obesity, or the effect of strokes, but to see how cortisol level, perhaps cortisone level is one of the main things in stress in pregnant women. And we know about the negative effects of neurodevelopmental effects on the baby, on the fetus. So we know that these children have a higher rate of autism, which is very prominent now in our society, that autistic children are more and more visible, and you see that they are it seems to be that they are raising, and what is causing the mothers nowadays more cortisol level or whatever, because then you think about the generation in war, what the mothers suffered of not knowing whether their husbands are coming back, whether having not enough food, and why is autism raising now? So there are a lot of things we don't understand, but I think I'm absolutely with you, we have to understand, otherwise we can't do anything about it. I have no answer.
I saw just the study when in the United States, because of this whole fortification system of grain, I think, with the foliage. I'm very careful to say this, and it should be treated with very carefully, but too much foliage has been already connected epidemiologically to all the rates of the autism in children, which is scary,
It's very scary.
because that's counterintuitive.
Absolutely, absolutely. I think sometimes it takes 20 years to realize what we did wrong, like feeding the babies as hell, but it was a long way to treat these children. So, and to supplement with folic acid, perhaps we think it reduces some other problems, but perhaps it causes some new ones. So,
it turns up, so immune disease
absolutely. Absolutely.
It is epidemiological evidence, but it's scary when you look at those new publications coming up that we have overdone. I mean, not in Europe, but in the United States, but they seem to have overdone it. It's a very interesting field, a bit of my expertise, apart from the book, but books that I've read, but it's a very interesting point for new generation to go into, and I'm very happy that there's more and more recognition coming from the clinical standpoint, and then, well, I'm not objective here because I work with epigenetics, but the huge field of epigenetic research that's developing at the moment.
But this is a very new field. It's 20 years old, isn't it? So, yeah.
Exactly.
Okay. Thank you.
Thank you.
Thank you.
Thank you very much. My name is Noriska. I'm a neonatologist. And maybe I have no question for you, but I have a short comment. When we are talking about fetus programming, we have to think also about microbiome. Because we know that the mother, pregnant women microbiome can influence on microbiota of newborn. And maybe, for example, maybe way of delivery is not fetus programming, but, for example, we know that if a newborn is born by cesarean section, this kind of newborn have really different microbiota. And now we know that this different microbiota is connected with, for example, obesity in the future and mental health problems. So in your scheme which you show us, for me it was not only on one point, this microbiota.
Thank you very much. I think you're absolutely right. With this microbiomic problem we are facing for the last 5 to 10 years, This is an issue in my theater. When we are doing a cesarean section, we try to give some vaginal fluid on the baby's skin for thinking about microbiome. So I don't think this is really a good solution, but you have to think about it. And it's the same way for antibiotics in the very early ones. So if we have antibiotics to give them for 1 day, we destroy the microbiome of the newborn. So this is an absolutely new topic, which is, but I think this is more or less, we can rearrange our attitudes about antibiotics and about cesarean section, but we can't change the placental function, which is so deeply inside. We have less possibilities to make that some changes. But you're absolutely right. Microbiomic is a very, very, like epigenetics. These are the themes which are coming up like whatever. They are the new ones which are very important to look for. Thank you.
Do we have more questions? Yes, thank you.
Hello, thank you for your talk. My name is Richter-Ehrenstein. I would like to speak referring to what Bata has already said, at Tomasz, and of course to your talk. I'm so sorry I missed the very beginning of your lecture, but I'm from the same group as Professor Boniesca, and I also missed one point in your lecture. It means microbiome, and it refers to both what Bata and Tomasz said, because regarding the emerging incidence of autism spectrum disorders, we know that the disrupted gut microbiome is due to high exposure to stress. And because of the stress, the adherence of pathogenic bacteria to intestinal barrier increases. Thus, it is associated with the higher incidence of endotoxemia, also in a pregnant mother. So maybe that is the clue, or maybe not the clue, but one of the other points that underline the importance of multifactorial origin of the fetal program. Thank you.
Thank you.
Hello, I'm the student in the 5th year, and my name is Anna. I'm before my obstetrics lessons, maybe this one will become basic. However, I was wondering, because right now we give much attention to our lifestyle, our fit lifestyle. And many pregnant women, or many women that want to become pregnant, are caring about their bodies, the changes that the pregnancy will do to their bodies, and they are scared to be weight gain. So there are some strict diets for them. And I was wondering if any of those diets can affect that much the fetus, and how to monitor those women, how we can we take care of them and suggest them some safe options, but not that won't be harmful to the fetus.
Thank you for your question. I think we see different developments in pregnant women. The larger you are looking for the women who are trying to be very healthy. Here they restricted their sugar consumption. They are trying to be not gaining too much weight. And sometimes they are vegetarian. That's quite a bit of a challenge, caring for these women, because they are most low of iron and all, which is depending on this. And I think we always have to tell our patients that they have to have a normal diet, which is very broad in in the field of having enough proteins, kohlenhydrate, and fatty things. And I think this is the minority of women which we have to care for. The majority, like in our clinic, are obese women. Most of them they are gaining weight like 30 to 40 kilos in a pregnancy, which is a really severe problem for the children, for the baby which is coming, and for the natural way to get the baby, to become the baby. So I think you are putting at the point on a very stressful patients population, because this well-informed, they have sometimes I think it's like a little bit of a not religious in a way to be Catholic, but it's more than only being healthy, it's more than being healthy. It's super, whatever, emotional. And this is not easy for us, because you have to get them down and this is not good for the baby, and you have to gain weight, 10 to 12 kilos, this is the normal weight gain you get in a pregnancy, in a normal one. But the others are more severe, in my view, the ones who are having 40 kilos add-on. So, but you're right. They're on both sides, it's a problem. But the most problematic thing in the moment for me is treating patients who are smoking and who have a regular alcohol consumption. And this is quite a problem in Germany. But probably in Poland as well.
I'm interested in this weight gain of pregnant women. How you say that normal weight? Because
10 to 12 kilos.
10 to 12. And what percentage of the population would follow that?
I think 50%, around 50% perhaps. But from my point of view, 50% are gaining 10 to 12 kilo.
Classes of this population.
Absolutely.
That was my second
Sure.
The average is the more achieved. So that if they have good care and your followers, which means the midwives and the doctors, pay attention to this one, is a majority of the patients included in this course.
Yeah.
But if the care is not satisfied, unfortunately, this also gain is too much.
Yeah.
And what would be the reason for gaining this overeating? Is this psychological? Is there any kind of underlying culture, or suddenly I can eat whatever I want and I'm just going to do it? What's the reason for that?
I think if we have an additional weight gain, you have 1 to 2 liter, 1 liter more blood, 1 to 1.5. Then you have placenta, which is 500 grams around. Then you have the baby, which is between a normal weight, like up to 4 kilos. So you have an at least 6 to 7 kilo baby, whatever amount, being pregnant. So the mothers then, which are eating normally, they gain weight, they gain water, they have more edema. They don't gain so much fat, so it's more fluid and whatever, because you lose your weight very, very fast if you're breastfeeding your child. Then the weight gain is, I think you lose it in 1 to 2 months if you have a normal weight gain. So this is not fat, it's more edema or whatever. But Sebastian, as an obstetrician, I think this is my point of view.
It's a uterus, amniotic fluids, baby. There's altogether there's 10 kilos.
10 kilo here around, yeah.
So why am I asking about it? Because we need a natural catastrophe to study this phenomenon. It's unethical to do it. We're not going to get the permission to do a study like that, like Dutch hunger or the stress study. However, if we have this phenomenon that 40% of women that gain weight, that would sort of reflect that experimental conditions if you compare them as with the weight to those that do not gain weight and try to see for the eating habits, then it would be kind of, complete opposite direction of the study. Instead of hunger, you have overeating. But this ethical committee would approve that, I guess.
I think it's difficult, but you are right. Yes, sure. But if you have we are seeing a rising population which have a pre-diabetical background. So lots of women develop diabetes type 2, gestational diabetes, and this makes a lot of difference for the babies as well. So you have different. So you can't compare these women, I think, with the others which are malnourished. So it's difficult. I think in a research-based study, you can't say, okay, you have to gain weight 20 kilos and the others have to gain weight 5 kilos. That would be a difficult ethical problem to make this kind of study.
The whole discussion goes on that malnutrition and not availability. I think we're in the opposite situation, and I'm not sure if that was studied at all, because for me it was new what you just said. That's why the question. I haven't actually thought about it this way. Thank you.
You're welcome.
Thank you very much. It means, many questions and long discussions always shows us how important this kind of meetings are and how interesting issue is touched by you.
Thank you very much. Thank you very much. I think may I have a short comment on these lectures? No, please stay. Please stay. I feel so honored. I think you have really, as students, the possibility of seeing a university for you, which is really that so many of your faculty is coming and talking to you and discussing things from their point is really exceptional. And I hope that you really worship this. This is exceptional, what you are doing as a faculty. So I'm very honored to be here as a little small guest lecture to see how you are working. Thank you very much. Thank you.
Thank you very much. This is a fantastic talk and fantastic discussion. Thank you to colleagues because we have absolutely experts on the field. Experts, neurologists, epigeneticists, microbiota specialists.
It's your faculty.
It is all what we have here. This is absolutely fantastic discussion and the concrete discussion because we have absolutely excellent lectures for you. And thank you for absolutely the discussion. And small for you. Thank you very much once again.
Thank you very much.
And if you have the question to Professor about the practical, then you have the possibility, of course. Thank the students because I know it's afternoon late, but I also this is university. This is absolutely true discussion, open lecture is all for you. Thank you once again for participating in this